We can see examples that are maybe not distributed evenly across healthcare, but there are dramatic improvements to be found, solving problems that people might otherwise say are sad but unsolvable. One of those leaders in the United States is Dr. Rick Shannon, who has had leadership roles. He's currently in many organizations. He's currently the Chief Quality Officer at Duke Health in North Carolina. He learned these methodologies from Toyota and applied them in hospitals in Pittsburgh, and this chart shows results from Pennsylvania. He repeated the same results using the same methodology, different people, at the University of Virginia. This is a very repeatable process of using lean methods, the tools and the mindsets and the leadership style to reduce, as we see on this chart, central line associated bloodstream infections, or CLABSIs. One thing Dr. Shannon did was, and I think this is helpful, is to state the number of infections, not a rate of infections. Like the number of infections, the number of patients, I think is easier for people to wrap their heads around. And through the lean methodology of studying how the work is done, making sure that everybody has the right supplies to do central line insertion and maintenance and removal the right way every time. It's from an improvement to what we might call the standardized work. It's not about telling people to be more careful or to try harder or to care more. They saw almost immediately a 90% reduction in these CLABSIs, and we can see reductions in other forms of causes of patient harm. There was a 17-day shorter length of stay per case. When you don't get a CLABSI, your hospital stay is shorter. And this led to a $1.7 million reduction in cost. Now we can break down trade-offs. Better quality does not cost more when we improve the way the work is done. Another organization that's done great work in this regard is the University of Massachusetts, UMass Memorial Health in the state of Massachusetts. As this chart shows, through lean improvement, by engaging people in improvement, and their goal is to have everybody, everywhere, every day involved in improvement, and this is driven by their CEO, Dr. Eric Dixon, we can see increases in patient experience scores. At the same time, we can see reductions in inpatient mortality. These types of improvements go hand in hand. When we engage people in improving how the work is done, and when we lead and manage them in a different way, when we equip them with tools and methods they can use to improve, we can see dramatic results in all of these key areas: safety, quality, delivery, cost, and morale. As an example of improving patient flow, this is a chart that shows results from a hospital in Wisconsin in what they call door-to-balloon time. Patients arriving to the emergency department with chest pain and a suspected heart attack. Door-to-balloon time, the end-to-end time from arrival to having the blockage cleared in the cath lab, is a key measure of, key predictor of outcomes. The quality of outcomes and survivability and recovery for patients. Steadily, over the course of 4 years, through a number of different process improvements, they got the average time down from 91 minutes to 37 minutes. And they, at least as this chart shows, were able to pretty much sustain that for a 5-year period. They went from that time being longer than the standard for good care to being much shorter. Engaging people in improvement leads to more improvement. It also leads to a better sustainment of those improvements because, again, they're involved in the change instead of having change forced on them.